My name is Lynn Helding, and I would like to welcome you to this webinar called After COVID Concerns for Singers. This webinar is brought to you by the National Association for Teachers of Singing, whose mission is to advance excellence in singing through teaching, performance, scholarship, and research, and also by the NATS Voice Science Advisory Committee. And I'd like to start by making some brief introductions. So I'll start by introducing myself. I'm Lynn Helding. I am professor of vocal arts and opera and coordinator of the Vocology and Voice Pedagogy program at the University of Southern California. And I'm also a member of the Voice Science Advisory Committee. My co-hosts this evening are co-chairs of the NATS Voice Science Advisory Committee, and they are David Meyer, Associate Professor of Voice and Voice Pedagogy and Director of the Jeanette Ogg Voice Research Center at Shenandoah Conservatory, and John Nix, Professor of Voice and Voice Pedagogy at the University of Texas, San Antonio. Our guest medical professionals this evening are Thomas Carroll, Director of the Voice Program at Brigham and Women's Hospital and Assistant Professor of Otolaryngology at Harvard Medical School, Michael Johns, Professor of Clinical Otolaryngology, Head and Neck Surgery at the University of Southern California and Director of the USC Voice Center, and Wendy LeBourne, Director of the Blaine Block Institute for Voice Analysis Rehabilitation and the Professional Voice Center of Greater Cincinnati, Ohio. We're also very pleased to have with us this evening NATS President Karen Brunson and NATS Executive Director Alan Henderson. Now, before we get started, I want to give our audience one more piece of technical information, and that is where to find all of the resources that we're going to be showing you tonight, including the webinar itself, which will be posted for later viewing. All of that can easily be found on the NATS page, specifically the COVID resources page. So that is www.nats.org, and the easiest way to find this is simply to go to the search bar and type in the word COVID. So with our introductions and our information safely stowed out of the way, I want to start by framing what we're going to be talking about tonight. All of us are aware that the voice news for singers because of COVID has been very bleak. And this is it's been a very sad time for us as singers. The title After COVID may have been a little misleading, as if to say, yay, it's all over. And of course, those of us who are reading the news know it's not. And so more properly, our webinar should have been entitled After COVID Infection. The impetus for tonight's webinar comes from the many conversations that we've had with our singing friends, and unfortunately these conversations typically center around three outcomes, and those are avoiding COVID infection altogether, contracting COVID infection and recovering from it, or the worst outcome, which is, of course, contracting COVID and dying from it. But there is a fourth outcome, and that is the focus of our webinar tonight. And this outcome is what happens to people if they have a COVID infection and survive it. What are some of the potential after effects? And because these after effects can include things like reduced lung capacity and intubation injuries of the larynx, things that are of specific concerns to singers, this webinar tonight will be just devoted to a frank discussion of those possible after effects. In addition, there are other after effects that are coming into view, which our medical professionals will also be talking about, things that are perhaps not specific to singers, but certainly can affect our quality of life. And we want to make sure that we leave you tonight with something that you can use. And so Mike Johns will be taking us through a risk assessment tool where it can help us make the decisions that we need to make about all of these after effects, these COVID-related after effects that could be possible. And we'd like all of you in the audience to be thinking about four broad categories this evening. That is physical effects, as we mentioned, that we'll be talking about tonight. Professional effects. What can happen to singers, not only in their singing career, but also in their teaching career, in their professional standing, if they were to be left, for example, with an intubation injury of their voice. The psychological effects that would come from harm, not only to the voice, but to professional standing and stature, and finally, financial effects due to loss of employment or medical bills. Now, the last thing I'd like to say before we give over to our first speaker of the evening is to stress an opinion that is out there in the world. And I have heard this myself. I've heard people say some variation of, well, I'll just wade into this viral pool and infect myself and just get over it. And it will be like a really bad case of the flu. But since getting over it could include some of these after effects that people who display this opinion may not be thinking about, we'd like to propose that singers and teachers of singers factor this information into their decision-making process. And the last thing I will say is, if the get over it view is not necessarily held by the singer themselves, but by their employer or someone who is in charge of their livelihood, it is our hope that the risk assessment tool will help these people understand why singers may wish to decline putting themselves at risk. So, in the spirit that knowledge is power, let's begin. Each of our remaining 5 voice experts has a presentation of approximately 10 minutes each, and our first presenter will be John Nix.
Well, good evening, everyone. I'm going to be speaking this evening about some of the risk factors for complications with COVID and comparing that to our membership, some demographics of our membership. And I want to thank Alan and the NATS office staff for giving me some of that information. So let's dive in. Who is at a risk for complications from COVID? Well, first of all, people that are 65 or older, people who have chronic lung disease or moderate to severe asthma, people with heart conditions, people who for some reason are immunocompromised, so maybe they're undergoing treatment for cancer, maybe they've been a long-term smoker, maybe they've received a transplant, people with immune deficiencies or HIV/AIDS, or people who have been on steroids for a long time. There are a number of autoimmune problems where people are on steroids for years and years and years. So they would be in this group. People who are drastically overweight, people who have sickle cell disease or type 2 diabetes, chronic kidney disease or liver disease. This slide shows how the number of cases of COVID varies by age. This is over 1.9 million cases from the CDC's resources. And you can see that the second column from the left, the 18 to 44-year-old age bracket, has the largest number of cases. Right next to that, however, is the 45 to 64 age group. A lot of our students are going to fall into that 18 to 44 range. That's your undergraduates and graduates and professionals and avocational singers. And then some of the upper part of that age group, and then the next age group, the 45 to 64, is going to be where a lot of our members are. You can see that the number of cases falls off drastically in the people above 65. However, on this next slide, you'll note that complication risk increases with age. Why is this? Well, the immune system is getting less and less strong as we age. So the CDC developed this rates for our hospitalization based on some very detailed information on a little over 30,000 cases. And you can see that as age increases, the number of hospitalizations goes up. Now let's compare this graph with the previous one. And you'll note that the number of cases, if you're looking at the people who are in that 18 to 45, that's where your really high number of cases is. And then notice that the 45 to 64-year-olds, that's still a large number of cases. Then look over on the graph on the right-hand side, and you can see that, after about age 50, the risk of, being hospitalized starts to ramp up rather steeply. So keep that in mind as we look at some other graphs here in a few moments. Also went in and I looked at differences by ethnic group. Non-Hispanic Native Americans or Alaska Natives are hospitalized about 5.5 times that of the non-Hispanic white. African Americans and Latinos also have much higher hospitalization rates than non-Hispanic whites. So far, it's not so much a matter of the fact that there are genetic differences, but rather a matter of health disparities, access to good health care that is driving some of these increased hospitalization rates. Now let's look at gender. There are slightly more women than men in terms of the cases, but if you look at the number that are hospitalized, a greater percentage of men are hospitalized versus women. A greater percentage of men also have severe complications and are put in an ICU, and more men die from COVID. Now let's take a look at the NATS membership, and I want to draw your attention in particular to the chart that is here on the table that's here on the far left side, and I've bolded some things there as well. Notice we have 66% of our members are between 40 and 69 years old. Remember that, okay? 66% of our members are in that kind of middle-aged group. NATS is predominantly a middle-aged, Caucasian, female organization. We are certainly diversifying, and that's wonderful. Thrilled to see that, but still, this is the most important information here over on the far left side, the percentages. So now let's look back at this chart, which we saw earlier. Now, if I'm going to flip back one more time, notice this is where the vast majority of our members are. 66% of our members are in this 40 to 69 bracket. Well, in that age bracket, we still have a high caseload, and that's also the time period where the number of people who are being hospitalized starts to ramp up. So putting all of this together, 2/3 of our membership is between 40 and 69. This age group still has a high percentage of cases and also a growing risk for hospitalization. Many of our students come from that next younger age group, which has the highest number of cases. And obviously there's more asymptomatic people in that age group as well. It's also in that 40 to 69 year age range where we start seeing other health complications on the rise. So things like high blood pressure, diabetes, heart disease, kidney problems, obesity. These are things that are not only genetic susceptibility, but these are lifestyle things, diet and exercise and getting good sleep and taking your medications. These are things that are lifestyle driven. And all of these increase the risk for complications requiring hospitalization and perhaps being put in the ICU. I would recommend our members who are from those higher risk ethnic and racial groups to be really sensitive, particularly if you have some of these other health conditions, which unfortunately are also rather often seen in those ethnic groups, high blood pressure, diabetes, etc. Our members who are in Alabama and Arkansas, Arizona, California, Florida, the Carolinas, my own state of Texas, and Utah should monitor the conditions in your states closely if you're not, as these states have experienced a doubling or more of cases in the last month. I'd also recommend getting this screening app. It was developed by Apple in collaboration with the CDC, apple.com/COVID-19. It guides you through a series of questions. You could use this every day, to kind of reevaluate where you are and check your temperature each morning, particularly if you're in one of these high risk groups. Obviously, consult your doctor immediately if you suspect you may have COVID. And I'd invite you to share this app with your students and your colleagues. So, using all of this information to assess your risks. Estimate the likelihood of your contracted COVID. So this is your probability of contracting it. And so this is based on things like your age, where you live, the activities that you participate in, the number of persons you interact with on a one-to-one basis, and compliance with the CDC guidance on behavior like wearing a mask and physical distancing, washing your hands. Next, estimate the likelihood that you might have complications if you contracted it. And so this goes back again to age, but also pre-existing medical conditions, your gender, your ethnicity, and your access to medical care. So this is how bad might it be if I got it. And we combine those two things for kind of a risk level. I'd like to share with you here one final thing. This is just a website you can go to, COVID-19survivalcalculator.com. And then it's available in English, it's available in many languages. And it will give you, a score which you can use to kind of inform some of your decision making. And again, I would advise you, ask you, maybe share this with your students and your colleagues and your family members. Thank you.
Thank you, John, Nick, so much for that. And our next presenter is Dr. Tom Carroll.
Hi, everybody. Thank you so much to Nats for organizing this. It's really a pleasure to be here and participate. I apologize for my orange color tonight. It seems the lighting in here is not ideal, but I think the message will be sound regardless. I was asked to talk about aerosolization, and I think this is a topic that, again, is more background information for singers. Many singers, teachers of singing, choral groups, et cetera, have been challenged with, how to sing in a safer environment. And the common thread of this is how do we avoid contracting SARS-CoV-2, and how do we, which is the virus that causes, which is the coronavirus stream that causes COVID-19. And I just want to give you some background on this. I don't have slides, so it'll just be more of a conversation. So there's really two types of transmission of SARS-CoV-2. The first type is direct, and this is what we think about when we talk about person-to-person contact. This would be a handshake or a touch of a person or a sneeze in your face or something where we get basically direct contact between two people. This can also be indirect if you touch a surface where there is viral particles on an object around us, and then you touch your face in a way that allows the virus to get into your mucous membranes or respiratory tract. The second way that it is transmitted is through airborne transmission. And this is the most important one that I hope you will leave here with a further understanding of, because this is the meat of why especially singers and teachers of singing and choral groups who are in especially closed spaces need to be aware of their risk. There are three sizes of particles that you'll hear about. The largest one is droplets. And droplets are particles emitted from the respiratory tract. They're larger than 5 microns, which is still a very tiny particle, but anywhere 5 and above, 5 to 20 is common. There are more of these large droplet-sized particles in cough than there is in speech or sneeze, potentially, but definitely more larger droplets in cough than in speech. And these actually are probably a minority of transmission. Some have estimated that about 20% of cases of coronavirus are transmitted through droplet, the droplet method. The second size on the other end of the spectrum are small particles. These are less than 1 micron. They're very small. They tend to come from deeper in the lungs and our alveoli. They carry little virus because they're so small, but they do float around for hours. So the smallest of particle size, again, carries little virus, but can be in the environment for hours floating in the air. The most concerning airborne particles are the middle size, the medium-sized particles that are approximately 1 to 5 microns. The reason these are most concerning is because when they're expelled from the mouth, from the respiratory tract, they float around in the air because they're small enough to do so. They evaporate, so the virus that's in them, which is larger than the smallest of particles, gets concentrated. What are called droplet nuclei. Smaller than 5 micron size because the particles shrink, and they do this immediately as they enter the air, and it concentrates their viral load, again contributing to the majority of transmissions. And again, these can float for hours in the air as well. It's long established that breathing and speaking lead to aerosolized particles from research and articles into the mid-20th century. As mentioned earlier, small particles are typically from the alveoli of the lungs. The alveoli are very small air where oxygen exchange occurs in our lungs. They believe this happens because of something called a fluid film burst, which happens when the alveoli shut and then open again during inspiration, and the particles get released. In addition to the alveoli of the lungs, there's laryngeal and possibly oral medium-sized particles in addition to smaller, larger. The vocal folds themselves also have a fluid film on them, just like the alveoli of the lungs. Voice and singing probably produces more medium-sized aerosols. Again, the medium-sized aerosols are the most dangerous. So this is why singers most likely need to mitigate their risk, not only from what's coming from deep in the lungs, but also from the level of the vocal folds and potentially the oral cavity. So about virology, how viruses are spread. It really comes down to 2 things: the average viral titer, the amount of virus in the droplet or aerosolized load, and secondly, the susceptibility of the host who is in contact with that viral titer. The viral load for a sneeze, for a breath, for a song that one could sing to cause infection is important. So however much virus is released for those actions plays a role in whether the virus can be transmitted. You may need a very small dose if you're somebody, as John mentioned, who may be an individual at risk. I know I'm having audio video issues, I'm sorry. Hopefully it will pick up. If it becomes bad, please let me know. The minimal infectious dose for one person may be very small compared to somebody else who may have a stronger immune system, etc. Theoretically, one viral particle may be enough to infect the right person. I read a good analogy recently by Dr. Malcolm Butler, who wrote about why everyone wearing a cloth mask is the next best thing to a vaccine. The virus has to find the right susceptible person. It has to infect that person through the respiratory mucosal route and then be in enough concentration to overcome their defenses. So the time contact with the virus and the viral load in the environment increase the virus's chance of infecting that person. And because large droplets and medium-sized particles are stopped by a cloth mask, small particles still escape the mask into the air. But remember, they are less infectious. So a cloth mask, not an N95, but just a cloth mask, is effective at reducing and mitigating risk because it stops large and medium-sized particles. So we also have to understand how aerosols move through the environment. Particles move through the air not just by where they're placed, but by how air moves them. So if two people are in a room, if there's air movement blowing from one person towards the other, it can move closer to that person or further away. So air movement, airflow, the space with or without airflow are all critical to the risk and understanding the risk associated with the coronavirus causing COVID-19. The particle size affects how the particles settle. We did talk about aerosolization and particles suspended in the air for small and medium-sized particles, but larger particles and droplets do have a higher viral load. The bigger the particle, the more virus that can be inside that particle. They can't travel as far or easily as deep into the respiratory system of the smaller and medium-sized particles, and they typically fall within 6 feet and settle in the environment sooner. But again, they are not the ones typically putting us at risk like the medium-sized particles. Room air turnover and size of the room are key to removing floating aerosolized particles. Plexiglass between singers will catch some, but not all aerosolized particles. Singers move around when they sing, they change posture, they move forward and backward. Distance cannot be guaranteed from plexiglass. It really is up to time of exposure between a student and a teacher or a choral group singing together, the size of the room they're in, the air turnover in that room, and how susceptible those members and participants are to disease. A distance of 6 feet between people is probably not enough, even with masks, to prevent the right aerosols from floating farther away. Even small particles that don't get stopped by cloth masks can get concentrated in a very small room without good air turnover. And a face-to-face posture between singers carries a higher risk of transmission, especially indoors. Couple final points, one on loudness. A recent study from the spring by Asadi et al. Demonstrated that increased vocal amplitude or loudness led to increased aerosolization. Particle size, like we discussed earlier, was slightly larger with louder speech, possibly from contribution from the vocal folds. However, overall particle size distribution was the same, even with softer speech. Some people were also shown to be potential speech super emitters who emit particles at rates an order of magnitude higher than others. And those people will not know who they are, most likely. And remember, finally, there's usually a 2 to 3 day symptom-free period before anybody knows they're sick, and particles and droplets and aerosols of all sizes are being expelled during this time, so there is significant risk for asymptomatic spread, despite no fevers, malaise, cough, etc. So we have to be cognizant of this as a singing community. Thank you very much.
Thank you so much, Dr. Carroll. Thank you. And next we have Dr. Mike Johns. I'm sorry,
next.
you are next.
Yeah.
Next we have David Meyer. Thank you, David.
All right. So I'm going to speak about the respiratory sequela for COVID. And sequela is a fancy word talking about the after effects. So what happens when someone has this virus and then recovers? What are the respiratory effects? And if you'll pardon me, I have a lot of serious stuff going on in my life right now, so I put some of my humor in here. I hope you don't mind. What are we talking about? Well, this is sort of the roadmap. We're going to talk about breathing for singing in the world's most quickly summarized scientific look at it, and it's going to be super, super brief. And then the respiratory sequela for COVID-19, the after effects, and why we should care. And I think there are some compelling reasons for why we should. And then looking at SARS and MERS as comparable epidemics, and some emerging data on COVID-19, and of course a take-home message. But a spoiler alert, if you're a person who likes to read the end of the book first, there are lasting respiratory problems for many people following COVID-19 infection. So, breathing for singing. Chi sa respirare sa cantare. That's an Italian phrase out of bel canto voice pedagogy that boils down to one who breathes well, sings well. And we used to believe this lock, stock, and barrel. There's exceptions to this. It's not 100% true, but it's at the heart of a lot of our pedagogy. Breathing for singing is crazy important. So here's how science looks at breathing. We basically look at flow, pressure, and volumes or capacities. Flow is how much air is moving out of your vocal tract per second. And on average, that's about 1/10 or 2/10 of a liter per second. Well, consider that the phrases we sing are usually less than 12 seconds in length. A phrase 12 or 14 seconds is really getting to be long. But do the math. If you sing for 12 seconds at 2/10 of a liter per second, you're only going to need 2.4 liters, and everyone who's healthy has that much. So we have enough air. Pressure is a little less intuitive, but the bottom line for pressure is that we make a lot of sound with relatively small amounts of pressure, and pressure is how we control loudness. Volumes and capacities, we typically have between 3 and 5 liters of air that we can move in and out of our lungs. Men will have more than women on average, and taller persons will have more on average than shorter persons. This just has to do with the architecture of your rib cage, of your thoracic cavity. When you have more space for your lungs to fill up, you can put more air in your body. Younger persons also tend to have more lung capacity than older people, and that's because the lungs are springy, they're elastic, and we lose that elasticity when we get older. And that matters for this COVID business. So, the good news and the bad news. More air is not necessarily better. You've got small lungs, well, you're probably a person who has small vocal folds as well, and small vocal folds take less air. So a soprano can probably out-sing a bass if the soprano has decent lungs and the bass has small ones. Small lungs usually go with small vocal folds. But the bad news is that we only have one way of powering the sound as singers, and that's the breath. And singers don't have more air on average than non-singers. And this goes back to a seminal study from a long time ago, but our total lung capacity between singers and non-singers is fairly similar. We use our breath very differently, though. If breathing is compromised via illness or via injury, the singing costs us more. And we usually pay that price with compensatory strategies that aren't so good for us, like pressing, squeezing, etc. So, Grumpy Cat says, who cares? I has no preconditions. I'm a young person and I'm not worried about this COVID business. And some of my students might feel invincible like this. Well, lung disease is common. It's so common, it's remarkable. Before COVID happened, almost 36 million Americans have chronic, preventable, and sometimes undiagnosed lung disease. That's remarkable. Consider that statistically, the big ones are listed down there. Statistically, that's about 1 in 10 of us. So if you're in a room with 10 people, one of you likely has lung disease, whether you know it or not. And these respiratory risks in COVID, we may sometimes underrate them. If our lung disease risk is 1 in 10, and if we're a person with a smaller lung capacity already, we're older, or we're female, or we're short, when we have smaller capacities, losing them makes a big impact on our singing. But regardless, if we're engaged in a profession where we really need to breathe, we're in trouble if we lose our respiratory power. We are, to borrow a term from my colleague, Dr. Wendy LeBourne, we are vocal athletes as singers and as teachers of singing. We need optimal respiration. So there aren't a lot of studies on rehab from COVID or on the long-term sequelae because it's a new disease. Good news, though, those who catch it, not all of those who catch it will need hospitalization. If you do, there's about a 50% chance, according to Murray et al., that you'll need long-term ongoing rehab care. So if you catch it and if you need hospitalization, God forbid, if you also need the ICU, there are some lasting post-recovery sequelae that are well documented from other disorders that one goes to the ICU for treatment for. And these different symptoms fall under the umbrella term of PICS, post-intensive care syndrome, and it sucks. It's stuff you don't want. You have problems with breathing, physical problems, cognitive problems, psychological problems. It's something you want to avoid if possible. There's very little data on COVID sequelae, but many of the scientific papers are currently comparing this disease to SARS and MERS, recent pandemics that have similar processes. And if you look at this one, this is maybe the ugliest page in the whole talk. 1 year out, SARS patients had respiratory problems that were persistent in this first study. In this study, we have between 6 and 20% of people had muscle weakness and mild to moderate restrictive lung disease after discharge for SARS. A singer who has mild to moderate restrictive lung disease, that is a huge handicap. Now in study 2 for SARS, about a third of these people at 1 year follow-up had persistent pulmonary problems. And again, for singers, this is a big deal. The overall health of those folks was also significantly worse. And in the last SARS study that I wanted you to be aware of, 97 survivors, about a third again had abnormal chest x-ray and reductions in exercise capacity 1 year later. And science is saying that SARS and MERS have similarities, although differences, to COVID. What do we know about COVID? We know we don't like it. We know that we're ticked off that it's here. However, there are lasting respiratory issues associated with it. Pulmonary lesions, alveolar injuries, and other problems. And many people seem to suffer decreased respiratory function after they recover from this disease. Now consider this, if you aren't taking this seriously yet, consider in this last study that 66 out of 70 people surviving COVID had lasting lung damage, as verified by CT scans right before they were discharged from the hospital. And these lung lesions took the form of clumps of hardened tissue blocking the blood vessels and around the alveoli, and lesions themselves around the alveoli. And these lesions can cause chronic, long-lasting lung disease in some people, not in everyone. But in some people, it's not very happy. Some lung damage will gradually heal or disappear. And it's very difficult to predict what will and what won't be a long-lasting, lifelong problem. Some lung abnormalities will harden into layers of scar tissue, and we call these pulmonary fibroses. And the scarring and these fibroses, they stiffen the lungs and are one reason for shortness of breath. And they limit your ability to be physically active. If you really care about hiking, if you really care about running, if you really care about playing with your kids in the backyard or dancing, social dancing, you want to try not to get these pulmonary fibrosis. And the one last thing that I'll say that rather sucks is that just because you don't have symptoms, you can be COVID-19 positive, asymptomatic, and have lung damage happening. And I don't like this, but I want to let you know about it. There's a brand new study, June 18th, that showed out of 37 asymptomatic cases coming out of China, if I remember correctly, 57% of them showed CT lung abnormalities. 57% of asymptomatic cases. And these folks, it was similar to walking pneumonia, and how they were asymptomatic and yet their lungs were being damaged is hard for me to understand, but there it is. So a quick analogy. If in my quarantine boredom, I decided to get going on some do-it-myself projects here at home, and I'm hammering away and I hit the hammer into my thumb really hard, I missed the nail, and I bust up my finger, it would hurt like the dickens, and I might say some words, and my 12-year-old might be like, hey, I would have a really bad day, but it wouldn't necessarily be a major life-changing event for me. However, if I were a concert violinist, that could be a career-ending event. In the same way, for your average person, slightly reduced respiratory function may not be super debilitating. Maybe they give up running. But for singers and teachers of singing, reduced respiratory function can be a career-ending possibility. Take-home message. Not everyone's going to get this virus, thank goodness. And those who do, not all of them will need hospitalization. And of those who are hospitalized, not all of them will have respiratory sequelae, although nearly all of them, according to one study. And again, the studies are all new, and we're getting better at this, so we'll know more soon. Many people, hospitalized or not, symptomatic or not, will have respiratory sequelae post-COVID-19. Singers power the sound with breath. We are vocal athletes, again, to use Wendy's term. It's a good one. Small changes in our respiratory function can have a big impact, a large handicap for people who rely on optimal breath. And I wanted to say a quick thank you to Lynn Helding. This is her baby. This is a wonderful idea that was hers. And the Nats Voice Science Advisory Committee, and also some good friends who helped point me towards some of this research. These are my references, and they will be posted with this talk onto the Nats website. Thank you.
Thank you so much, David. That was wonderful. And next, we would like to welcome Dr. Mike Johns.
Thank you so much, Lynn, and thanks to all of you for tuning in this evening. Hopefully this is informative for you. I've been asked to round out the discussion regarding the medical conditions that can persist after recovery from a COVID infection. So we're talking about chronic medical conditions, not the acute symptoms associated with the COVID-19 infection. And as a rule of thumb in medicine, when we're talking about chronic conditions, we're talking about things that last typically more than 12 weeks or 3 months. And so if you think about the timeline from when all this started in the United States, we're about at that 3-month mark. And so our understanding is just beginning to take fold about what some of the issues that people are going to be facing after COVID-19 infection. And so I want to emphasize what Lynn said early, that we're not talking about a binary situation where you either recover and you're fine, or you don't and you're dead. There is a spectrum of problems that are beginning to emerge. And it starts typically as stories, and we're reading more and more about stories of medical conditions that are persisting, and we then need to back that up by high quality science to give us good understanding. The good news is that I've got to say the scientific community and the scholarly community has really rallied, and this is the fastest generation of knowledge that I've seen in my career in academic medicine. But it's not a binary phenomenon, and it's not hard to make the leap that if you are have more severe disease, you're more likely to have longer lasting effects afterwards. And similarly, it's not a stretch to think that athletes in general are going to be more susceptible to physical perturbations than non-athletes. And I think it's important to include singers as vocalists and vocal athletes in this regard. So with that said, I'm not going to talk further about the pulmonary issues and complications that can happen, as David touched on this really, really nicely. And that likely is going to be the biggest sequela that affect the singing population. But there's other issues as well that are important to be aware of. And that's, direct laryngeal injuries or laryngeal injuries. And the obvious ones that come to mind are trauma related to intubation. It's a fairly rigid tube that's placed for mechanical ventilation. And for COVID-19 patients, the treatment patterns are generally towards later tracheotomy, which can have a whole host of issues around vocalization afterwards, much less breathing. But other issues can happen with the breathing tube being in place for a good period of time. So some of the common things that we see with prolonged intubation are injury to the cricoarytenoid joint, or the joint that the vocal folds sit on. And so we can have motion abnormalities of one or both vocal folds with significant voice swallowing and sometimes airway compromise afterwards. But also with the tube in place for such a long period, you can have soft tissue injuries. And if you remember, the vocal fold tissue is incredibly resilient when you think about how many oscillations of the vocal folds happen, of course, a day of voice use. But nonetheless, mucosal injury that occurs from a tube being there can lead to scarring, and we just don't have good treatment for vocal fold scarring at this point in time. But those are kind of the obvious things, the direct mechanical trauma from having a breathing tube in place, but there's other conditions that present in the larynx that we know from our experience with other viruses. And one category is a neurological weakness, so vocal fold paresis or paralysis that can run the spectrum from being very mild to a complete paralysis of one or even both vocal folds, but more commonly one. And the severity of symptoms that result from this is directly related to the severity of weakness. But in a singer, subtle asymmetries of vocal fold control and contractility is going to manifest itself. And so that's another category of laryngeal complications. But there's a third that we see as well, and has yet to emerge whether we'll see this in the COVID era, but I would not be surprised if we did. And that is in a category of problems that we call neuropathy. That commonly manifests itself as laryngeal hypersensitivity. And so these are chronic cough. These are problems with proprioception, meaning knowing where your tissue is in space. I think we've all had situations where you may be sitting with crossed legs and one of the legs goes numb for a period of time and you have a lot of hard time with motor control. And so the neuropathies can manifest in that way, and fine and subtle control. So those are the kind of the three common categories of laryngeal problems that can happen after a severe viral illness like this. But we're also seeing issues related to the hypercoagulable state. So with COVID infection, the coagulation system gets disrupted and we see increased clotting occur. And that can present as strokes. It can present as soft tissue loss. If say a tip of a finger or a toe or something like that can become necrotic from such a hypercoagulable state. And so that's a significant category of problems that we see. There's emerging evidence regarding neurologic issues that can occur, cognitive issues, neuropsychiatric problems. I just read an article today that there is at least unmasking, if not association, with some neuropsychiatric conditions and COVID infections. And similarly, this condition sometimes leads to severe inflammatory state in the body and a lot of injury to our major organs. Cardiac issues, chronic cardiac issues result from acute cardiac issues. Chronic kidney issues result from acute kidney issues. And you say, okay, well, the kidney issue is not going to affect my voice. Well, it certainly can, because that organ is one of the prime regulators of our body's fluids, and we know the changes that can happen even in the larynx and voice, even with subtle changes in our overall body's fluid status. And lastly, I just want to speak about chronic fatigue, and this is something that seems to be emerging as a common sequela from people who've recovered but may not have more serious, if you will, medical conditions afterwards. But in terms of your ability to function in just day to day, get up, get out of bed, have the energy to do common tasks, much less demanding physical tasks, can be compromised. And so that's just an overview, a smorgasbord of some of the conditions that can occur following this. And the real take-home message is this just isn't binary. It's not, okay, I'm over it, or I'm not and I'm dead. And so these are the factors that we've got to keep in mind as we function in society. So thank you, Lynn.
Thank you so much, Dr. Johns. And next we have Wendy LeBourne, who's going to speak with us.
Hi, I am working on my slides here. Just a second. There we go.
Great. There we go.
Thank you, Dr. Johns and Dr. Carroll, and everybody for being on tonight. You know, we have lived in this world of being in a place where theater has essentially shut down, and my vocal athletes have, you know, like everyone else, are out of jobs at this point. So we want to look at, again, long-term impact, and as Dr. John said, what is chronic versus what is acute, and we're really only just now at that 3-month mark. So I've seen some of my first patients come through who've had COVID, who are professional vocal athletes, and had conversations with probably 15 to 20 other vocal athletes. What I can say, not that we're, you know, rainbows and sunshine all the time, but in the 1918 pandemic, what we do know is that everything was written. So if you look into Variety and other publications, they've gone back into the literature and taken a look. You know, vaudeville didn't die. We came back in 1920 to be able to have live theater again. And I, you know, shed some credit for Matthew Swanson, who looked into the archives of the May Festival Chorus, which is one of the oldest non-professional choruses in the country. And what we know is that May Festival Chorus performed in 1918, and at that time they were an every other year choral organization. They didn't perform in 1919 because they weren't scheduled to, but they were back in 1920. So we know that music survives. We know that theater survives. It might look different, and how does it look different? We also know that professional athletes do participate in sporting activities with asthma and slightly compromised lung function at times. And as singers, if you've ever transitioned to different altitudes, you know that that certainly affects your lungs. Not the way that COVID does, but I think we have to have some positivity in this, that we are going to emerge on the other side of this. So about 5 days ago, when this all came to fruition, I sent out a survey to my professional musical theater Broadway artists. And thank you to Dr. Carroll for also sending it out to his resources. And we actually had about 53 respondents to see how they are doing about 3 months out from potentially contracting the virus. So this is new information that we haven't really shared with anybody yet. You're the first to see it. And this is what things look like. So we know that Broadway, all theaters shut down on March 12th of 2020. For the national tours here in the US, Miss Saigon was the last national tour to close. And thank you to my artists who confirmed that for me. And their last show was on March 15th, 2020. Once on this island, closed in Las Vegas the day before on the 14th. Miss Saigon closed in Fort Myers, Florida on March 15th, 2020. And at that time, things were just really blossoming. And this really follows the trends of what John Nix has already reported. So it's not surprising to anyone here, but of the folks that participated in my research, about 50% were in that 25 to 34 age range, or venturing up into that 44. We didn't really have anybody in that 55 to 64 age range or above 65, which is often where our voice teachers fall. And so we do need to take a look at some of those teachers that are post-COVID. I actually spoke with one not too long ago who was in that 55 to 65 plus range and who had COVID. And the reality is they actually are doing okay, but one of the spouses is still sick and the other one is recovering. But they've all had different symptoms with it. Again, corroborating what John Nix has reported by the CDC, in this particular group of 53 people, we saw the majority of them being female as compared to male. And whether that has to do with who were seeking attention for their illness or not, we don't know. Just to give you an idea too, of the folks that I looked at, 28% of the respondents were Broadway or off-Broadway performers, and then 72% of them were regional theaters, national tours, cruise ships. They were actively auditioning in New York City, or they were in rehearsals. So this is the demographic, and it's, I'm sorry, a little smaller slide, but the vast majority of people who responded to this survey that were elite vocal athletes were actually in the New York City area at 65%. We actually had 4% that were in London. We had 1% that was in Cuba. So these were some of my touring performers that were out and about or rehearsing another show in another city, and some of them were on tours. If we look at the reported date of when they actually started to experience onset, it was really that March 15th, 1st to 15th, and 16th to 31st of March timeframe for our artists. The majority of them reported, 52% actually reported that their acute phase lasted somewhere between 1 and 10 days, but 48% of my elite artists reported that their acute phase lasted 11 days and beyond. So that is slightly concerning. You know, this is not your typical flu where you get it for 48 hours and you're done, but we do know that within about 14 days, they're done with this or somewhere thereabouts. For the folks that reported in this study, 67% of the reported folks in this study, which we're going to look at their symptoms here in a second, but 67% of them were 12 plus weeks out. So we're now at that chronic phase, if you will. We want to consider 3 months chronic when we start looking at this additional data. As far as who got tested and who didn't get tested, because that is still part of this conversation, about 50% either were swabbed or antibody tested and tested positive. 52%, 53% approximately didn't get tested but had all the symptoms. You have to remember that in early March in New York City, it was not easily accessible to be able to have COVID testing. So we want to think about these folks as they might not have been able to get testing, but they had all the symptoms. So acute versus chronic, we're now at that 3-month mark. And we have to think about, you know, when we're looking at singers, we have these singers who generally fall in this, what we're expected by CDC guidelines if you're over a certain age or if you have certain health conditions, but we have these outliers. And on the one side, we have these very non-symptomatic, and I couldn't find a picture of vocal athletes who are non-symptomatic, but physical athletes who are non-symptomatic, right? And then they test positive and not knowing. We have someone who's in the middle, like Adam Perry from Frozen, who just came out on ABC News and talked about his long-term effect. And we have our really severe severely affected vocal athletes, folks like Nick Cordero, who are still in ICU at like almost 90 days plus having initial diagnosis, who is a healthy, fit individual. And these are our outliers. So we want to think in the middle. So this is what we know. So I asked them what their physical health and their vocal fitness was pre and post COVID. So on the left side of this screen, you're going to see their self-rated physical fitness pre-COVID, which is, you know, in the 60s, close to 70%, and post-COVID, they're feeling 53%. And post-COVID, or pre and post-COVID for vocal fitness, we dropped from 77 to 57%. Whether that is because they're not performing actively, potentially, but the reality is the majority of them don't feel vocally or physically up to where they were prior to getting COVID or having COVID-like symptoms. We asked you know, as Dr. Johns talked about the variety of symptoms that we see, the biggest issues that we saw here happening were related to headaches, were related to body aches, and then we get into the respiratory symptoms, muscle joint pain, and voice symptoms. The blue are the pre-COVID the acute COVID symptoms, and the orange are current day, like what they're feeling now. So you're assuming the majority of them are 12 weeks plus out. The other symptoms that they're experiencing, because you see that orange jump up there, when I took a look at their responses, the majority is physical fatigue, that they just don't feel physically like they used to. And when I've talked to some of my artists who have had this, they vocally feel okay and they respiratorily feel okay, but not back to normal. But physically, they're fatiguing much quicker than they would expect to fatigue. So this is reflected also in their concerns returning post-COVID. Vocal fatigue, I asked them, if you had to return to your pre-COVID role today, what are your biggest concerns? And their biggest concerns were actually vocal fatigue, vocal dynamics, so power. So if we think about that, that goes back to respiratory. And then the feeling weak or physically fatigued rank up there pretty high. Breath support ranks up there, and then we see range is decreased and shortness of breath. Until these performers are actually outperforming, I'm not sure we know the total effect of what this looks like. But this is a starting place for us to be able to look at this for our performers. So with that information, this is a starting place. We know that theater comes back, but we just don't know how. So I thank you for letting me be a part of this conversation, and I look forward to seeing what the next steps look like for our vocal athletes.
Thank you so much, Wendy. And wow, thanks to all those people who responded to your survey so quickly. That's just wonderful. Next, we have Dr. Mike Johns, who's going to talk us through this risk assessment tool that will be available on the NATS website.
Thanks so much again. So as a way of a bit of a capstone here, and to put things together and maybe provide some this useful tool, hopefully, we created this. It's really more of a decision assistance or reflection tool for teaching singing during this pandemic. And it's important to point out there's really no formula that's going to give you a definitive answer for maximizing your safety for yourself and others during the pandemic. So these are points that you can use for self-reflection and discussion with your peers and students and supervisors and whatnot. So first and foremost, remember the overarching principle that Dr. Carroll so nicely talked on, that dose times time is risk of infection. So low dose, long periods of time, higher risk. High dose, even short periods of time, higher risk. And obviously the other two scenarios are pretty obvious. So we put together kind of 5 questions really to think about. And the first is the fundamentals. And this is the stuff that unfortunately we don't seem to be doing a great job at presently in our societies. We're seeing more and more infections on the rise, reminding us that we are not out of this. So the fundamentals are the things that we know work. Masking, physical distance measures, hand hygiene, frequent disinfecting of surfaces and all the items, doorknobs, materials that we contact. And the CDC has put together useful resources in this regard. And so it's worthwhile reflecting on how, our colors just changed, on how well you are adhering to these and how well are the places that you are going to are adhering to these fundamentals. Second is risk. Do you know your risk of contracting severe disease? And this is the link that John Nix put up. And it's worthwhile going on and online and using this or a similar tool just to get some sense of what is your risk for contracting severe disease. The results may surprise you. do this for yourself and those in your household. Third, take a critical assessment of your workplace. Has your voice studio, or have you assessed your voice studio to minimize risk? If not, do so. So we know poor ventilation and confined spaces are higher risk environments. Robust ventilation, open spaces, lower risk. Enhanced filtration can play a role. We've installed HEPA filters in all our endoscopy rooms in our clinics appropriately for extra level of safety. And consult with your facilities management if you're able to, because these folks can actually take some measurements and can make modifications in the systems that are around you to improve safety. Keep in mind that the singing world is different because of the aforementioned reasons regarding increased aerosols and speech super emitters. And so enhanced precaution in the workplace environment is certainly warranted. And the CDC has put together resources for facilities management folks to improve workplace environments. And the fourth component is workflow. And so this is getting to the time equation in the dose times time quotient, if you will, a product really. So have you critically assessed your teaching schedule? Longer contact times with more individuals is higher risk situation than shorter times with fewer individuals. So it's important to have a look at that. And then lastly, we put this category as citizenship. And this is a reflection point on our roles and behaviors as possible transmitters of disease. And it's not just what's my risk of getting infected, what is my contribution to this pandemic in general, and what's our moral obligation to contribute to the well-being of society. So this will be available just as a reflection point and as a decision assistance tool. And thank you very much.
Thanks so much, Dr. Johns. And now we would like to turn to our NATS president, Karen Brunson, for a few words from her. Welcome, Karen.
Thank you so much. This has been enlightening. And we have to, I first wrote deal with reality, but actually we need to understand it. And that's the way that we can deal with it. I know I was asked to do a survey, and it was from a major opera company. And so I took the survey, and some of the questions in it would say, when do you feel like you would return to be part of the audience? When do you feel, would you feel safe if this many seats were between you? And it hit me that feel is not a good thing to go by. Yes. That there are facts that you can assess your risk, and regardless of what phase we're being told that we're in, we're seeing in too many cases that that's not lasting. And so I need to make my own decisions and stick by them like glue, and share that with my family and students and whoever will listen. And I know my church has often reached out to me in the past weeks wondering, what do you think? And what do I think? I know that COVID is present, and that when we sing, it is more present, possibly, if there's somebody in there with the infection. So we are so thankful to each and every one of you for doing this. And Lynn, this was your baby. And those talks that we had with you beforehand that led to this were mighty sobering. And yet we have to hear this. We have to know it. So.
And thank you, Karen, for bringing up that point. I hadn't thought of that, gosh, it kind of goes to Mike John's citizenship question, doesn't it? That there are people who know us as singers and teachers of singing, and they're asking us, they've read the stories in the newspaper, and they're asking us what we think, or as you said, how we feel. Mm-hmm. And so we have to replace that feeling with the facts that we know. So thank you for mentioning that. That's a really,
thank
really
you
important point.
For everything you're doing, and I know there's probably a ton of questions out there.
I think there are, and I'm going to segue over to Alan Henderson, who I believe is going to be fielding some of those questions. Hello, Alan.
Hi. Welcome. Thank you so much for this information. We do have a couple of questions. And first of all, I will just say, yes, the document that Dr. Johns outlined is shareable outside of NATS. It's freely available on the website. It's there now on the COVID resources page. And I also have notes from Dr. Carroll for those who are asking with some audio glitches, which we think will be fine on the recording. And those will also be posted. So that alleviates a lot of people's worries. One question we have here, do we have any idea how many of our colleagues in NATS have contracted COVID? We do not know definitively. I know of half a dozen to a dozen NATS members who have had COVID myself. And I'm not sure of my colleagues how many of them might know of more than that. Anyone?
NATS members or just people?
The specific was NATS member. The specific question was to NATS
And
member.
I would ask, let's have all of our panelists go ahead and turn their video on. If you're not speaking, stay muted, but let's see everyone's beautiful faces here. So does anyone have anything to offer to Alan's question?
I know of one.
One NATS member.
You know, I think that from my standpoint, I could take the survey that I did, if NATS is interested in it, and flip it so we could present it to NATS members to have an idea of how many NATS members, because I think the demographic that I looked at maybe wasn't representative necessarily of voice teachers, but of vocal athletes. And Alan, I would be happy to kind of transition that survey just a little bit to be able to find out. And then maybe we would have some additional information to provide if that's something you are, as a NATS community, interested in.
That would be wonderful. Consider it done.
I'll try to get that to you tomorrow.
Tonight is Wendy's anniversary. She will not get it to me tomorrow. Get it to me later. Another question we have, did I hear correct that increased loudness does not increase viral load?
I can field that one. So the increased loudness led to an increase in the medium-sized particles overall. So it was, if you have more medium-sized particles, then you have a chance of more high concentration of virus floating in the air versus the tiny particles that only have a small amount of virus to start with. But the average amount of the spread of particles from small to large was the same, whether you were doing a whisper versus a loud voice.
Great. Let's see, I think those are the main questions people have shared so far. Okay, here's one. How big a room might be safe to teach a voice lesson? What distance would be safer? UV light systems. Any information, thoughts? Thank you for all the care and information. I will give you a little bit of information on that if you come to the boot camp session tomorrow, we will be having a guest from Michigan who is manufacturing some UV room units, and they're going to demonstrate those for us tomorrow. So that's a good reason for you to come to the boot camp, among others.
I mean, I can make a brief statement, Alan, if you want. You know, the real answer is it really depends on ventilation, and it depends on all the things that we talked about. There's no cookie cutter formula to this at all. The best room is outdoors for anybody. So really take that into consideration. If you can get, as Mike pointed out, if you can get some semblance of what your air turnover time is in your studio, that would be helpful. The problem is not always, for example, in our world where we're scoping patients, it's not the patient you're scoping now, it's the next person walking into the room who potentially could walk into a situation where there's aerosolization that's occurred. That's, our scopes are probably less risk than a singing lesson, I would be easily presumptive to say. So just be careful and get as much data as you can. and wear masks when you're singing with each other if you have to do it inside. John looks like he has something to add as well.
Yeah, just following up on what Tom was saying. Tom was lead on a group article that Mike is on, I'm on it, David Meyer is on it. It's an all-star cast of laryngologists, especially. Ingo Tietze is a co-author. We have speech pathologists. Anyway, that article is going to be in the Journal of Voice here very soon. And as what Tom just said, being outdoors is probably the lowest risk thing you could do. Opening windows and having natural ventilation. Of course, that's a pipe dream in South Texas and a lot of other places in the country where you have these climate-controlled buildings. So be looking for that. I know Dr. Sadaloff has arranged with Elsevier for that article to be available with open access. And Alan, you might want to speak about, how we're going to get that out.
Yes, we have a.
Can I jump in, Alan?
Yeah,
One other thing.
Yep. Also on the COVID resources page, we have a updatable spreadsheet with many academic articles on COVID, which Deanna McBroom has curated for us. And lastly, tomorrow afternoon, we'll be sharing with you an estimator tool, which has been developed by the researchers at the University of Colorado that, we're not going to go into depth in it, but we want you to know about it. Just, and Deanna and I will discuss that a little bit briefly.
And all I was going to say, in addition to what John and Tom have already said, the safest way of doing this is through a computer screen. And there's aspects of that that simply aren't optimal, but there's no comparison for the safety. There's a paper that is in review right now with a good friend of ours, was the senior author on, Dr. Christian Herbst in Austria, looking at a survey of voice teachers and the use of this tool. And we have a lot of exciting information going on. I would rather this period be horrible for a short amount of time with a tool that's not optimal than prolonging this.
Yeah, I'd like to add to that too. David Meyer and I have been working, and John, in the Voice Science Advisory Committee on tech as applied to voice lessons. And I've been making the pitch for a long time for low tech, that tech doesn't always mean computer voice analysis. And now look where we are. We've been sort of forced, right, for all of us to use this new tool. So my NATS presentation this time around is called Cognition in the Time of Coronavirus, and that's going to be published this fall in the Journal of Singing. And I just tried to give teachers some very nuts and bolts ideas about how to approach this. So since my research is cognitive science, I really approached it from a different way of thinking about all of this. And instead of us feeling sad and mourning the loss of our standard voice lesson, which we all do, I think it's important to really think about what tools are available to us that are very low tech, that all of us can use, and we've kind of been forced to use. So some of those resources are out there too, and as Wendy said, we will get through this. We will get through this.
More questions now.
Oh, there are more questions.
More.
Oh boy.
Do medical air purifiers have any positive effect?
So we're talking about enhanced, I guess, filtration really here, and this goes in the same category as like the UV sterilization system. So all these are measures to reduce infectivity of aerosolized particles. Keep in mind that the core fundamentals still are at play. The touching, the hand contact, the surfaces, the doorknobs, and what probably is the remains the high-risk zone. Right. But certainly adding enhanced filtration is better than not.
And somebody brought up UV light earlier, Alan, and I think it's important to realize that that's not something you can be in a room with it on while you're working in there, as far as I understand. So
you'd be getting a good tan, Tom? I mean,
you would get a serious tan, I think. And I do know physicians who have employed them between patients earlier in the COVID crisis, but I think it's less practical from a, just contact time in the singing environment. Can't use that.
I'm not aware of any studies supporting the efficacy of face shields alone. Anyone else?
That's in the paper that John and Tom and 40,000 other authors and I are on. Yeah, I am not aware of anyone else.
I'm not. I looked at one of the ones with masks alone and looking at the shift of masks. But I mean, I think Dr. Carroll, Dr. Johns, and I, certainly when we're all going in procedure now, we've got like glasses, N95s, face shields, hair bouffants. We look really pretty. I don't know about you guys, but I feel quite glamorous. This is about as glamorous as it gets.
I mean, I feel lucky in my hospital's been great about getting everybody tested before they even walk into our scope room. So we've been fortunate in that way to know that at least within 2 to 3 days, people walking in are COVID negative. And people ask, oh, well, how do you know there's not a false negative rate? Well, they've done studies on our population for people coming in for elective surgery who had no symptoms, and there's less than a 1% chance that they actually have it. So we're pretty fortunate to have testing available. But yeah, the answer with the masks is we know that even a cloth mask can mitigate larger and medium-sized particles, but they don't mitigate all risk. Even if you're both wearing them in a face-to-face situation, separated, the room and the time you spend in it with an infected person makes the biggest difference.
So I'm assuming that would be your answer to this question. I did not hear anything about singing with masks on. I'm a choral director and I've been asked this question. Correct?
I'd like to jump in on this one. Of course, it's hard to get research subjects at this time and to be in a booth with somebody. But my wife, of course, has DMA in voice and has been on voice faculty at a number of schools. And so she and I are going to go into my booth in my lab, and we're going to the one thing that we're going to look at is what we call the alpha ratio, basically the balance between low frequency and high frequency components in the sound. And we're going to use the disposable surgical mask and then cloth mask and then without a mask at all, and just look at a little comparison. Again, this is 2 subjects, but I did a really full search for this, and I only found one study, and it was actually looking at different kinds of masks and speech intelligibility. I'll be happy to share that reference. Basically, the surgical masks are the best for intelligibility, and they do the least amount of attenuation of the sound at high frequencies, but you would expect that. They're the thinnest masks. So I'll get that reference to you, Alan, to have it up for everybody.
And I'm going to jump in here too, John, because I've actually played with them as well. So I've played with my N95 mask, a surgical mask, a cloth mask, and then I have a mask that also has a vinyl window in it so my patients can see my lips and my mouth when I do this. The problem is when I sing with any of these masks on, with the exception of the N95, when I take a breath in, it sucks to my face. And so it's really hard, especially if I'm singing loud. I mean, this is just anecdotal, but when I'm singing, because I've played with this, it's hard to not get these masks to suck to your face with normal breathing for singing. And then after wearing them all day, I'm not lying that my jaw, I definitely feel some tension in. Now, whether that's just me or not. The N95 is interesting because I feel like sometimes you could maybe get some resonant voice going on with an N95 mask because they're a little bit different shaped, and I don't get the suck to my face. But that's just been my experience in using them since probably late March, early April.
I did want to also add, Ron Scherer shared with some of us on the Voice Science Advisory Committee. He did just a little study of himself with an N95 type mask, looking at acoustical effects, and basically it's like, as Wendy was saying, it's like a little extra, extension of the vocal tract there, so it lowered resonance frequencies, 100 hertz or so. But that's about all the stuff there is, because people haven't been able to go into labs and do a lot of studies right now.
I heard anecdotally too, Wendy, there is a mask that's more like a duckbill, so it doesn't have that suck-in effect. So people could look for something like that, just to because it is annoying. I feel the same way, even just talking to people that constantly getting the mask in my mouth.
But a great opportunity for innovation. And
right.
We've seen so much innovation come out of this, and the mask development for us to be able to safely scope people without having to have rooms and whatnot. So for those of you who have some engineering prowess out there, get to it, because it can be made.
Yeah, I actually heard that Under Armour is actually coming out with a mask for like running, cycling, stuff like that. In the next couple of months, you can pre-order those. Not that I'm supporting them or any other way, but from an exercise standpoint, that's a lot of it, respiration too.
I think we have one more question on this. This might be a really good mention of something else the Voice Science Advisory Committee is doing. Is there a way we can get a list of those low-tech options for teaching voice lessons? David?
Absolutely. So the Voice Science Advisory Committee has 3 articles that are being worked on right now from its members. And we're looking at 3 different articles for the Journal of Singing. And with any luck, we're going to have those submitted by the end of the summer, if I'm optimistic. Those 3 articles are no tech, as Lynn was saying, no computers, no fancy electronics, no tech, low tech, and high tech. For many people, they think of voice science as spectrograms and expensive equipment, and we want to share ways that it can actually impact your teaching in a very approachable, user-friendly manner. Low tech, no tech, high tech.
Thanks. Alan, do we have any more questions, or?
I think that's great.
Great. Well, we asked our panel to think about what thought they would like to leave with our audience tonight. So I'm going to just go in the order that we went to begin with. So I believe, if I have that correct, that's John Nix, followed by David Meyer or Tom Carroll. I'm not sure. Tom's next. Okay, then David. I know. And then Mike Johns, and then Wendy, and I will go last. And just ask everyone to think about what is a thought that you would like to leave our audience with. So,
well, those of you who are my age can probably remember the TV show Hill Street Blues, and every day they had their, convo of all the officers, and then right at the end they were all getting ready to go, and the sergeant would say, "Hey, let's be careful out there." So that's what I'm saying to you all.
Great,
Excellent.
Thank you.
So I guess my biggest take home is just consider other people and consider yourself. I mean, I think look at your own risk first and foremost, and if what you're doing professionally puts you at undue risk, it's probably not worth it. Look for alternative solutions.
Great, thank you. David.
Me. So my take-home message is that singers and teachers of singing need their lungs to do really remarkable things. So do your best to avoid getting this virus, because it can have lasting effects on your lungs that you don't want. So do your best to stay safe. Stay safe out there.
Yeah, thanks. Dr. Johns.
So if you ever wondered why surgeons wear masks when we operate, the answer is pretty obvious. It's to prevent infections.
Yeah, wonderful. Well said. Thank you. And finally, Wendy LeBourne.
I would say wear a mask, please wear a mask. But I think that this is going to give us a stepping stone for we've almost gone 15 years in the future in 3 months because we've had to, from online voice training to everything else. So not that it's all rainbows and sunshine, because it's not, but I think this gives us a starting place to move forward. Thank you for my artists for responding. Looking forward to hearing from our NATS voice teachers to say, okay, we have to take step 1 before we can take step 2. So for us to find you a safe way back, let's look at what your risk factors are and how you're doing. So please stay positive, because we will find a light at this end of the tunnel that's not necessarily a train coming at you.
Excellent. And I'd like to end by saying something that I say to my Vocology classes, which is knowledge is power. And I just want to say to everyone who's listening tonight to please think about the things that we've talked about tonight. And when and if you encounter that person in your conversation who says, well, it's inevitable, I'm just going to get this thing and it's fine, I'm just going to do it and I'll get over it, to please help them think through all of these potentially, yes, they are frightening things that could happen, but knowledge is power. And in that spirit, we wanted to offer some of those potential outcomes to our audience tonight, just so they can make smarter decisions. And I think another common thread we've heard tonight is smarter decisions not only for yourself, but for your family members, for your friends, for your colleagues, and for your community members. And after all, that's a big part of who we are as singers and as NATS members. And so in closing, I really want to thank also once again our president, Karen Brunson, and our executive director, Alan Henderson. Thank you so much for supporting this idea. Thank you.